Well, good morning. I am Al Harvey. I'm a member of the Lewis Thomason Law Firm, and we are one of your sponsors. And we have the honor of being a sponsor because we feel so strongly about the problem that we're dealing with this morning and this afternoon. Our firm has been a specialist in healthcare law for over 50 years. We've represented physicians and hospitals and others. We recognize this is a situation where law and medicine intersects, and unless our professions work together, we will not be able to solve this problem. So it's an honor for us to be one of your sponsors. I'm also on the faculty, adjunct faculty here at the law school. I teach a course on national security law. And I've noticed that a number of my students are here this morning. They all get extra credit. You may be wondering why a student in national security law gets extra credit. And the reason is that the opioid problem is multifaceted. I teach in this course Homeland Security. And Homeland Security is absolutely affected by what we're dealing here with this morning. This is your first panel. It will deal, will deal with the revolving cycle of overdose, of treatment, of payment, reimbursement, and how all of these intersect. We have two lawyers and two physicians. The moderator of the panel is Kathy Stoyer, who is the Senior Associate Counsel at St. Jude Research Hospital here in Memphis. Kathy is and has worked on a number of issues involving patient care and medical research in her work at St. Jude. She also comments on the Board of Medical Examiners and the proposed telemedicine regulations. She has served as the immediate past chair of the health law section of the Memphis Bar Association, and she is a graduate of the Harvard Law School. The second lawyer on our panel is Dakasha Winton, and Ms. Winton is the Chief Government Relations Officer and the Senior Vice President of BlueCross BlueShield of Tennessee. She has offices in Nashville and in Washington, D.C. She's responsible for state and federal government relations efforts. Ms. Winton has served as Chief Counsel for the Tennessee Department of Commerce and Insurance Division on insurance. And she is a graduate of this law school, and we are very pleased to have her on the panel as well and welcome her back to Memphis. Our two physicians, one first from the University of Tennessee is Dr. Sean Ham. Dr. Ham is a professor at the University of Tennessee Health Science Center on addiction medicine. He completed a residency in family medicine and then a fellowship in addiction medicine here at the University of Tennessee at Memphis. Dr. Ham is a specialist in addiction medicine and is certainly welcome on this panel. Our second physician and the fourth member of our panel is Dr. Cassandra Howard, who is the Chief Medical Officer for Methodist Hospital Germantown. She is also a colonel and medical officer for the Tennessee Air National Guard. Dr. Howard has been in her position at Methodist Germantown since 2014 and certainly recognizes the problems that we're dealing with. She did a residency in internal medicine and pediatrics at the University of Tennessee. And for the past 29 years, which I think is very significant, she has served the United States Air Force and the Air National Guard and is currently the Tennessee Air Surgeon assigned to the Joint Force Headquarters in Nashville. So we're delighted to have all of the members of the panel. Will you please help me welcome them? Ms. Stower.
Thank you very much, Mr. Harvey. We really appreciate that lovely introduction, and we're very happy to see everyone here. As Mr. Harvey said, our panel is focusing on, in significant part, the cycle of addiction and the interventions that may or may not be sufficient from the provider and payer perspective. I first would like each of our panelists to please introduce themselves, give us some background about their work and how it is affected by the opioid crisis that we're here to discuss today.
Can everybody hear me okay? Good. So my name is Dakasha Winton, as was noted earlier, and I'm the Chief Government Relations Officer. So when you think about government affairs, you don't tend to think about how are you interacting with the opioid crisis. So just to kind of give you some insight, last year over 600 bills were filed in various legislatures to try to address the opioid crisis. There are constant actions in Congress to try to address the opioid crisis. At BlueCross BlueShield of Tennessee, on behalf of our 3.4 million members, we pay for about $18 billion worth of prescription drugs last year. That is a phenomenal number. And the things that we do, and what we try to look at, first thing that we do is determine whether or not something is safe, and then we look at the costs, which is what most people expect for the insurance company to do. And how the opioid crisis has impacted our costs is they've made them rise very significantly. And so we look at it in a very holistic way as to how, as a health plan, we can try to address that crisis. So that's what we do.
Good morning. Can you hear me? I'm Dr./Colonel Cassandra Howard. I was an ER doc at Methodist Germantown for about 15 years. We currently see a population of about 60,000 visits per year. As you know from this symposium and the media, increasing number of those patients are patients with drug addictions. We treat a lot of overdoses. Unfortunately, a lot of return customers, so not the best way to rack up frequent flyer miles. But it has impacted our business. It impacts the care we provide to other emergent conditions or patients presenting. And part of our discussion today will kind of give you some insight into my perspective as the provider looking out at the epidemic as I interface with my pre-hospital providers, the EMS paramedics that are on the scene treating patients, and then how it affects our ability at the hospital, ER level, and inpatient level. How do we care for these patients and ultimately get them definitive care and the limitations associated with doing so?
As I said, my name's Sean Ham. Finished my residency in family medicine, did the fellowship in addiction medicine, and now I'm happy enough to be a professor at the university teaching other fellows how to specialize in addiction medicine. I think, as university, we're involved in the clinical aspects, research. We're also involved in outreach, community outreach, as well as prevention. As you can imagine, especially in my clinic, let me back up. Addiction is more than just the opioid crisis, right? So we see a lot of other addictions as well. But a majority of them right now is dealing with people who are suffering from an opioid use disorder. I don't know if you want me to kind of talk a little bit about addiction first to kind of define it a little bit. So, and there's lots of different definitions. Some are longer than others. I usually like to think about it as, it's doing something despite adverse consequences, right? And now keep in mind, there's behavioral addictions to gambling and stuff, but for purposes of this, we're just going to talk about substance use. It's also important to remember that addiction is it's a chronic relapsing disease. It is something that it's not short term. It's compared a lot to diabetes, right? And I think that kind of analogy fits really well. Somebody who's diagnosed with diabetes, we treat with medications, lifestyle modifications, diet, exercise, education. And so addiction is the same way, especially when we're talking about the opioid use disorder. When you're talking about that, it's about using a substance, right? It's just a compulsion to use a substance, in this case, opioids, and then a lack of control on the limit of that substance. Okay, they can't stop using it, and then when they're not using it, it's associated with negative emotions and stress, which kind of also drives more use. I will have to a little bit talk about, so one of the main neurotransmitters involved in all addictions is dopamine, okay? So that is in our brains, it's there for reward, okay? Everything we do, when you're hungry and you need something to eat and you finally eat, you get a little hit of dopamine. When you're thirsty and you finally get something to drink, you get a little hit of dopamine. It's the same. So it rewards us for good and normal behaviors that are necessary, for survival. Okay. Opioids in particular, they end up releasing. They're very efficient at releasing high amounts of dopamine, higher than a normal physiological level. Okay, and so the way I think of it is, when someone does heroin, when they first start or whatever, they get this huge spike in dopamine. They become euphoric, right? Well, doing that a couple of times over and over, your body, your brain tries to put things in what's called homeostasis. It tries to put things back in balance, okay? So because it needs you sober. So what it'll do is it'll downregulate dopamine. It will make less dopamine. It'll reset the hedonic tone that is naturally there. So then what quickly happens with drug addiction, particularly with opioids, then the person's kind of drive for use ends up being just to feel normal again because they have less dopamine around now that has been reset. So I think that's important to kind of consider. Do you want me to keep going? Or?
I thought your water analogy last night was good.
Oh, right. Well, that has to do with... So last night we were talking, and this was more about the stigma associated, and we'll probably get into that a little bit later, with addiction. So a lot of people view addiction as, it's a moral failing on the part of the, person who has the disorder, or, they don't have a strong will. And so I've even had those arguments at my table because, my dinner table, right? And the way you need to think of it is, so this is my, I don't know if I should say this, my mother-in-law.
Tell it. I know his mother-in-law, I'm telling you.
But it's really common, right? So it's kind of like, well, why can't they just stop? And so the way you need to think about it is, I told her, I was like, well, you just finished drinking, you just went to the bathroom and everything. You can live 4 days without drinking any more water. You know that. Your prefrontal cortex knows that. That's your thinking part of your brain. I just told you that. Don't drink anything for 2 days. Don't do it. Do not do it. You'll live. I'm telling you, you'll live. You'll have 2 days cushion, if not, and but you're still going to want it. You're going to have that drive to drink. And so people with addiction, particularly opioids, it is more profound than that. It's even a bigger urge to do it. And again, that part of your brain that we're talking about, that is we really do call it the reptilian brain, right? The lizard brain. It really is there for these normal maintenance things, And so it also never shuts off. So when you go to bed at night, it's still there, and so you can't override it with, the things that people who are suffering from addiction have to learn, like, in other words, coping skills and support systems, and we'll probably get into that.
Thank you. That was very helpful. So when talking about the revolving door of what Dr. Howard was saying earlier with the EMS responding and patients going to the emergency room and then getting treated for an addiction, being released, and possibly having not enough treatment or not wanting treatment and returning to the emergency room, I wondered if you could comment a little bit more on that, Dr. Howard, and then we'll move into some thoughts on what led us to the epidemic.
So typical life in the ER, the life and times of an ER doc. So you're in the ER, and part of the rush, you never know what's coming in next, right? You guys watch ER on TV. It's nothing like that. But it gets to the point where some of our patients, you don't need a chart, you don't need a medical record number. When you see them, you know what your encounter is going to be, and it's going to be some story about knocking the bottle over and everything falling down the drain and you need a full refill, or it's the patient who is just very honest and they're so low in life, they don't care that that they're opioid addicted or they're using heroin or they're using fentanyl. I've seen some patients so desperate they've taken the sustained release 72-hour fentanyl patch that's used for patients with chronic pain, say metastatic cancer to the bone, which I wouldn't wish on my worst enemy. It's just a horribly painful existence. So one of the ways to give that patient, for example, sustained pain medicine delivery and get them some day-to-day just going through life relief is to put on this opioid patch and they'll get sustained delivery of this medication. We have a patient who comes in, he chews them, takes them from his grandmother, and he chews her patches because he's just that desperate. So if her mail order refill doesn't come and there's a gap in fentanyl patches available at home, he comes to the ER and he wants pain medicine. So our struggle is, how in the midst of treating the person having an acute MI, heart attack, and the person behind them having a stroke, you have to stop and deal with, eloquently we call them dude, not to violate HIPAA. You have to stop and treat dude, and dude recurrently comes in, and again, you try not to vilify the patient, but unfortunately in the ED, we get to know these males and females as just kind of the revolving door patient coming in seeking. Sometimes you'll open a chart and it'll be big, bold, large font, bold and italicized, drug-seeking behavior. That's the discharge diagnosis. Our EMS partners are plagued with the same thing. What do you do when you respond to an address 2 and 3 times in a 3 or 4 hour period and you're giving an antidote to revive someone, restore their breathing, because they've overdosed, and before you can make it back to the station, you're being called back again because this patient has overdosed yet again. So one example I shared with the team is we have an EMS council meeting where all of the ERs in the city meet up with all of the EMS providers and we discuss our issues in providing care within the city. And they noticed their cost of Narcan, one of the reversal agents, went from $18,000 at their cheapest year, and it was up to $97,000 that they had spent. And they said, we can't sustain this budgetary line item, and we may just need to intubate these people. Put a breathing tube down their throat, put them on life support, and deliver them to you, and you guys just have to deal with it. At my facility, we have 16 ICU beds. In our medical ICU, we have 16 beds in our critical care cardiac ICU. We're full right now, but if every EMS call, they intubated an overdosed person whose brain basically is asleep and not telling them to breathe, and delivered them to my ER, we could not sustain, that volume. So, it impacts us to that degree of being able to provide care.
And for the non-medical folks, they're intubating instead of giving the narcotic reversal agent.
Instead of spending that cost of constantly
even though the cost of having someone in an ICU
astronomically greater.
Yes.
So it's a continuum, it's a spectrum, and like Dr. Ham said, he's treating these patients on the outside, trying to treat and manage the addiction, hopefully prevent their recidivism in the ED, but a lot of times in the ER, the easiest thing is to treat their pain and then try to get them connected to an outpatient treatment option. But if they have no provision of care, they don't have insurance, they don't have several $1,000s cash to be enrolled.
Right, and so that's a really big barrier to care. And so and she probably sees this more. The ER is the perfect place, right? That they're there, and you have this window of time in which they want help. But the difficulty is that window closes really quickly because it's hard to. There's no warm handoffs, right? Sometimes you can't admit. You cannot admit for an opioid use disorder just because you're withdrawing from heroin. You will not die. And that's so I can't admit for that. I have to look to see. They have to have electrolyte disturbances or
Something medical.
Right, exactly, something medical, and so that's difficult. And therein lies part of the problem. So usually what happens is they want help, they're desperate for help, you can't help them, and then you can't place them anywhere. Addiction is a career of narrowing options. So usually there are a lot of times they've lost their job, they've lost their family support system, and they don't have insurance. So it's definitely something that needs to be addressed.
So we call Miss Winton and we say, fix it.
And we say, well, we try to say we try to get involved into various options. So when we talk about officers or individuals that do not have access to naloxone, we provide that to various police agents across the state through a grant to make sure that those areas do get access to those things. So we have to try to do some very non-traditional, out-of-the-box thinking in order to address those issues, because otherwise we just have a revolving door. And for some of those individuals, we cannot help. If you do not have insurance or you're not insured by Blue Cross, you may be insured by someone else. There are ways to try to get on maybe Medicaid or other options, but just because you're poor doesn't make you qualify for Medicaid. And most people, they don't really understand that it's not just access available all the time. So that's a tough thing. So that means everybody has to think a little bit outside of the box and to try to address the issue.
So Narcan is a drug used, to resuscitate somebody who's, overdose, but it's not a cure. It's not. In fact, what usually happens, if you hit somebody with Narcan, they wake up pretty angry because it puts them immediately into withdrawal. And again, those are not pleasant symptoms. And so they will probably often get mad and leave the ER.
We are not their heroes when we do
that.
No,
not at all.
And unfortunately, there's nothing I can do legally to force that person into treatment. I can't force them to want addiction treatment. I can't force them not to leave the ED. There was a patient who, a local restaurant in Germantown, ordered lunch, sandwich was being made, went to the bathroom like most of us do to wash our hands before eating, and his girlfriend noticed he didn't return to get a sandwich. And when she went to the bathroom to check on him, he was lying on the floor unconscious. If you're an ER doc, you assume it's an overdose. If you're, a soccer mom, you may not assume everybody who's collapsed in a restaurant bathroom has overdosed. So the paramedics arrive, and that's her differential diagnosis of one is he's overdosed. And they're like, well, how do you know? Because he just did it a couple hours ago. So this fire unit arrives, brings the patient to Germantown. By then, he's awake and alert because they've given him 3 doses of Narcan. There's not a look of satisfaction. They're not ripping their shirt open, Superman, they've saved a life. They're very disgusted and pretty much tired of this guy because they're constantly having to do the same thing. So he gets to me. He doesn't even want to be registered. We're wasting his time, and he's pretty upset that we've interrupted a very expensive high. And so he leaves, and within an hour and a half, he's back. He went to a different location, overdosed yet again, and the same unit brought him in. And that was the threat. If he does this again, we're going to intubate him and just put him down, and then you can watch him in the ICU, but we can't keep responding to this address. So that's the cycle that we're seeing. But legally, I can't strap this guy down and force him to get treatment. I'm actually at fault, and that's abuse, because he has the right to refuse care, because at that point, he's fully decisional and able to say he wants care or he doesn't. Now, on the flip side, there's some people that kind of wake up and they're like, man, I'm in a really bad state. I need to do something about this, doc. I need help. And that's that moment of surrender. That's that window of time, that short-lived opportunity where it's not a battle, it's a partnership. But then the record scratches and you wake up and you're back in reality because, the music stops playing. And it's, do you have insurance? No. Do you have how many thousands up front to register for? What does it normally cost?
So I mean, if you go to a lot of these facilities, residential inpatient treatment facilities, they're private pay or private insurance. I mean, it's pretty expensive, and it's just 30 days. Again, we're dealing with a chronic problem, and that's just short term.
For this one, I think it was going to be $5,000.
That's right.
Out of pocket that he would have had to pay to leave my ER to go into treatment for 30 days.
Yeah.
So.
And as a result of that, you've had some people come in. They've been very, entrepreneurial in this sense of creating this whole situation. And so we see this in like Florida and California where these addiction centers are not actually addiction centers at all. They prey on someone going to the emergency room and they can't get into a real addiction center. So they say, hey, you have private insurance. Let us help you. And they put them on the plane. They take them to either Florida. They take them to California. They pump them full of more drugs. And the minute that the insurance company figures out that, hey, this person shouldn't be there and we're not going to cover that individual anymore, they ship them back. They put them on the bus and they say, sorry, you got to go figure it out. So these are the types of things that are happening, and it's such a terrible cycle that we're trying to address, but even sometimes we can't even get it fast enough.
Interesting. So I want to just, so when you're treating opioid use disorder, it's essential, now not, there's not a one-size-fits-all, okay? But it is typically it's essential to put the person on what's called medically assisted treatment, and there's 3 FDA-approved medications for that. But it's not just the medicine alone, right? I mean, again, it's that plus the behavioral. It's about cognitive behavioral therapy. It's 12-step facilitation support groups, and I can go on, right? It's those things together that equal less more sustained recovery or more chance of recovery. Some people are able to do just abstinence, right? But what we're finding with the opiate use disorder, it's in a year there's only 10% that actually are able to achieve that. So there's 3 different medications that you probably hear about. One is methadone, that's been around for 40 years. It's a full mu agonist. It's the opioid receptor. You also hear about buprenorphine. Buprenorphine is people know it as Suboxone. There's the monoproduct Subutex. They have other names, Zubzol and Bunavail. And then there's also naltrexone. Naltrexone is it blocks that receptor completely. It has different. It's like a Vivitrol injection is probably what you hear the most about. So, but and I think the trick is, or the skill, like anything, is trying to find the right fit for that patient, right? And it changes. It's not always. It's not always the same. Some people can be stable and in recovery for 3 years and everything's fine, and then something happens and they triggered or whatever, and then they relapse. So it is something that's constantly changing. Okay. But she is right. There's also this other aspect of drug treatment centers, right? And it's just very. What I've learned is there's, they're therapy driven, right? They're therapist driven, and so they are not. They don't want to. There's no real medication plus therapy, and so usually that can be a problem, I think. I mean, it's interesting because they'll be in treatment for, say, 30 days, they get discharged, and then they relapse 2 weeks after being discharged. So,
do y'all have any thoughts on what has actually gotten us to this point that we're here talking about an epidemic? It's been declared a national health emergency. Do you have any, we've heard a lot about the impact of the epidemic on your practice and the barriers and the challenges that you're facing in your own practice and in getting treatment for patients and getting us out of this. What has led us here?
I think we would all agree up here that it's definitely multifactorial. There's not one entity or one point of failure. As a physician, I will tell you, when I was in training as a medical student and as a resident, there was a very clear focus then on pain being the fifth vital sign, as we used to say. You know, we'd measure your blood pressure, we'd measure your heart rate, your respiratory rate, your oxygen saturation, and oh, by the way, you better ask about pain. And during that period of time, physicians as well as hospitals, we were judged on how effectively we addressed and managed a patient's pain. And the ruler wasn't how many morphine milligram equivalents of morphine you gave or which agent you used, A versus B. It was the patient's attestation of how well you controlled his or her pain. And I will tell you, you know, as an ER physician looking backwards, I cannot dismiss the fact that that is probably at least part of the causal factor. When I walk into a room and in the back of my mind, or, you know, now as a vice president, chief medical officer, we're being judged on how effective our patients report when they're getting some type of patient satisfaction or patient loyalty survey, how well we managed and treated their pain. So if I'm the opioid addicted addict, whether it's heroin or fentanyl or Lortab or Percocet, and I come to the ER and I complain to Dr. Ham that I'm in pain, and Dr. Ham knows that this is my 10th visit of the day, and he says, you know, he addresses me very frankly and offers me help, and I refuse, and I get a survey, and I'm asked how well, you know, how did he listen to me? Was he compassionate? Did he care about me? Did he address my pain? Did he effectively manage my pain? What am I going to say? You know, so as a physician on the front end, you know that you're being judged on that. And I mean, there were lectures I sat in on, you know, sit down because the patient will perceive the duration of time you spent at the bedside was twice as long. You know, we had lectures on which pain scale to use. Do you use 1 to 10? Do you use the FACES model, you know, where you go from being happy to sad? It really is. But you know, we had to do it, you know. And so pain was the fifth vital sign. And, you know, when you got to the point where compensation and referrals and all of that were based on you being graded as a physician, whether it was 5 out of 5 stars or the A through F grading system, it definitely affects your behavior at the point of encounter with your patient. In the ER, as a medical director, I had to counsel some of my partners because it was really easy to have a quick encounter and get to that next patient if you just gave a 3-day supply of pain medicine and then sent them out to their primary care provider or Dr. Ham to deal with long term. The patient was happy, the doctor was happy, it was a quick, timely visit, you know, and you move on to the next one. And so I think that was part of it.
Yeah. It's interesting. I don't know how true this is. I heard this though, that when the debate was going about whether, you know, pain was the fifth vital sign, they actually were trying to consider, you know, oxygen saturation. So you know, why would we pick that? I mean, it's a quantifiable. I mean, it's on
Right.
exactly what it is, but we're not going to pick that. We're going to pick something that's, you know, yeah.
Subjective, very subjective.
I think there's more. You know, obviously overprescribing, you know, like she said, plays definitely a big part of it. But, you know, for every ill, there's a pill. I think that, you know, we as a society believe that. And, you know, in primary care, I mean, it's true. I mean, I've seen people come in and you know, they're complaining of cold symptoms in 3 days. And I know it's, you know, I'm just, you know, gambling. It's you know, 80% of the time it's a virus. The virus, antibiotics aren't going to help with the virus, but they want something. I mean, I don't give it to them, but they're not pleased with it. We think that you know, there's a fix, there's a quick fix. You know, I mean, I really think, you know, the more you're always smarter looking back. But, you know, I think that the behavioral stuff, we need to really evaluate medicine as a whole. I mean, you know, again, diabetes, you know, no one prescribes the medication. Here, take this insulin, now go eat whatever you want. You know, it's the same way. I mean, how many people, I have family members, you know, have high cholesterol, whatever, and they still live in Memphis. No, I was kidding. They have high cholesterol. They're prescribed a statin, but they're still eating biscuits, and they can't give up the biscuits. And so, right. And so, I mean, I think that it's the behavioral stuff that we need to kind of, it plays into it, and I think that that's probably also a reason why we got in this.
And of course, I think when you have an entity as large as an insurance company paying for the drugs really without any type of limitation, so no matter what the doctor prescribed, however much, we were paying for it. And it wasn't until maybe 7 or 8 years ago, there's a small town in East Tennessee named Jellicoe, and I don't know if many of you have heard of it, but Jellicoe, they were probably getting prescriptions in the numbers of the hundreds of thousands. And there's not even 10,000 people that live in Jellicoe. And so we started looking into it and started saying, oh my gosh, we have a huge problem. And before we knew it, we tried to, for the prescribers, we were like, we're going to kick you out of our network. Well, unbeknownst to us, the TBI is sitting in that office because they're trying to figure out what's going on. And we send the doctor a letter saying, we're about to kick you out of the network. The TBI contacts us and said, no, you will not. You will rescind your letter. But that is what is required. So what we had to learn from that process is collaboration. And throughout all of this, we have to collaborate because otherwise we find ourselves in situations where we're not technically supposed to be in. But Jellicoe was the real reason why, as an insurer, we learned in Tennessee how bad the opioid crisis was because we honestly did not, we did not have a clue.
So, one possibly often alleged, true or not, cause of the epidemic that we haven't touched on yet is whether overprescribing is at fault. So Ms. Winton mentioned that in this one town, but that sounds like an extreme case. But there's a question as to whether overprescribing, say post-surgically, has contributed to the epidemic. And I'm interested in your thoughts on that. But what I would really like to use our remaining time for is to say, assuming that were true, and we heard from Governor Haslam on the recording this morning with Tennessee Together, the big plan to address, that is one example of restrictions on opioid prescribing, requirements for checking the Controlled Substance Monitoring Database. We also have the Tennessee Pain Management Guidelines. We have prescribing guidelines from the Center for Disease Control and multiple other organizations that are involved in trying to tell physicians how to prescribe and how to practice medicine. And I would be interested in whether you think that is the right path. So it's a little bit of a compound question in terms of, does that contribute in your experience? And either way, are we on the right path in these legislative and guideline initiatives, and then also from the payer perspective and with what Blue Cross is doing?
So from the provider's perspective, and I probably speak for ER physicians staffing 6 Methodist ERs in our city, we're very supportive of it and appreciative of it. I will admit we moaned and groaned when Tennessee law mandated that we do a 2-hour prescribing course if we were going to prescribe controlled substances in the state. We moaned and groaned about it, but we all walked away like, man, we talked about things we learned, perspectives that we weren't aware of. Also, as a military officer, I have a DEA license, and as a privileged provider in the United States Air Force, I too have to do 2 modules of education as a prescriber of controlled substances, because at any military location around the world, you could treat obviously someone with a need for pain medication. Again, the problem is multifactorial. I don't think legislation alone fixes the problem. When you look across the spectrum of who abusers are, they're not, just heroin users or fentanyl users. There are some patients who we introduce to opiates. Does every ill require a pill? and does that pill need to be a controlled substance? So as a provider, the legislation, the restrictions have actually given us a new scope. You know, pain was the fifth vital sign. Now it's not, but it's still important to address. And we are so varied on our willingness to prescribe, what we prescribe, how much we prescribe, how often, and who we prescribe to. I think that those restrictions help narrow the scope to make it a little more safe. It also makes it very easy for me to look at my revolving door returning patient to say, hey, you know, I recognize you're in pain. It's not a crime to be in pain. However, there are better, safer ways in which you can have your pain treated. And Tennessee state law mandates that I instruct you of that. They mandate that I check the prescription monitoring database to make sure I'm compliant with those rules. And by the way, your report is 12 pages with 15 providers, 10 different pharmacies, and multiple agents. And I know most of these providers by name are ER physicians. So, hey, recognize this isn't safe, and let me introduce you to my buddy, Dr. Ham, and let's see if we can better control your pain in a safer manner. So I think it's helpful, and I think the physicians, once we got over the initial kind of grumbling of being forced, voluntold, as we say in the Air Force, to do all of this training because, you know, we went to school for umpteen years and you don't need to teach me how to write a prescription. Once we got that education, we realized we were part of the solution and we welcome it.
So we had a lot of physicians get really upset with us. We implemented a prior authorization process for any long-acting opioid. So the provider would have to submit information to us, several things. One, if there was a plan to taper the individual off of these long-acting opioids. Two, what type of pain did the individual have that warranted that prescription. So the doctors had to provide some additional information. And when we implemented that back in January of 2017, they were upset. We got some nasty, nasty letters. However, as we've proceeded in the process, we've gotten some phone calls from people saying, you know what, I'm really grateful that you guys implemented this plan because it allowed me to do a better job with my practice. We also give providers a scorecard, and it compares them to other providers in their area to say, hey, here's where your prescribing practice is, and here's where everyone else is around you. And so just to inform providers, to let them know, hey, here's where you are, and here's where you stand, and here's some things that maybe you can do to improve upon that. But it's really trying to be more collaborative than just, hey, hammering down. Because at the end of the day, as an insurance company, we can deny your claim. I mean, all we're saying is we're not going to pay for it. Like, if you still want to go out and get something, you absolutely can go do it, but that doesn't mean that we have to pay for it.
So,
See?
You notice I'm sitting between the two of them, right?
No, that's not like that at all. I think she's right. I mean, I think we do need to be collaborative. When I do hear when I hear guidelines and restrictions, and it's a double-edged sword. I think that there are times when I really do welcome it. I like it because it allows me to keep rapport with the patient, right? So in other words, when I know this patient doesn't need something, right? It's like, hey man, it's not me, okay? It's just, this is law, you know? I mean, I literally say over and over again, like, listen, you know, no one makes me prescribe these medications to you, right? But if I do prescribe, I do have to prescribe in in an appropriate manner, and it's not appropriate for me to prescribe this for you. So no one makes me do it, but if I do it, I need to do it like this. So, I mean, I do think that they can be helpful. They can be harmful, too, because not everybody fits into this perfect little matrix. Something it has nothing to do with you personally, but it's interesting, prior approvals. I hear that, and I'm like, So
We don't like them either, by the way.
Well, no, but it's interesting, like what a barrier, for example, in my group, it's not just me, there's other prescribers. And so if I have a patient on, a TennCare patient on a medicine, and I get the prior approval, and it takes 3 days, which again is weird when it comes to a window of time. I've got somebody who hasn't used or in active withdrawal because, hey, the guidelines say they have to be in active withdrawal in order for me to prescribe, right? You have to get a COW score, which is a clinical opioid withdrawal score. Anyways, I got to wrap it up. So. So if I prescribe this, there's a window, there's 3 days, have to wait, and then say I'm not there, and another doctor is there in my group with the name on top of it, and they write the prescription and sign it. That prior approval needs to be changed again to that person. I mean, that's kind of a barrier.
Any final thoughts, recommendations, and we'll wrap up? Not sure how much time is left.
We're done.
We're done. All right. Well,